Good morning, everybody. I make it 9:30. Welcome. Particular welcome, I think. I can't see her on. As if by magic, Lucy, I was just about to say welcome to you joining the board meeting for the first time. We have apologies from Lynette Wells, and I wanted to draw your attention to the list of the Hero of the Month winners. And some of you will remember that we suspended doing the sort of monthly staff recognition during the worst of COVID. We restarted again in the summer. And one of our regular contributors, Mr. Campbell, reminded us that we used to report on these and that we'd overlooked doing that since the restart. So we've corrected that now. I have to say most people will know that I meet all of the winners personally, spend a bit of time with them, hand over their certificate and their prize, and we usually have a bit of a laugh and a joke. I suppose it would be wrong of me to say that's one of the best bits of my job, but it is indeed one of the best bits of my job, getting to meet people who win the awards. It's great. So this month we've got both August, September, and October for you to look at, and we'll continue this as a standing item every public meeting from here on in. So let me move to declarations of interest. David, did you have something you wanted to say?
I should just say I have an interest in item 9, Chair.
Thank you, David. We'll come to that in due course. So minutes of our last meeting on the 12th of October. Miranda.
It was just to say that my name is omitted from the people who were present, but I definitely was there. Indeed, I am quoted in a couple of places.
That would seem to confirm it then for certain, wouldn't it?
Yes.
Thanks, Miranda. Apologies for that.
No worries.
So with that amendment, are people happy that the notes are an accurate record of the conversation? And unless somebody shouts out, I'll take silence as agreement. Thank you. We've no formal matters arising, but I wanted to give colleagues the opportunity to raise anything from the minutes if you have them. Jackie.
Just on the question of the discharge lounge extending its opening, has that progressed at all, just out of interest?
Who would like to pick that up?
I'll pick that up if that's okay, Chair. We are in the process of looking at how we can extend our discharge lounge. But actually what we're doing at the moment as part of our Winter Sparkle campaign, which I'll refer to a bit later on, we are actually making sure that we're utilising it fully in hours at the moment. So it is a recruitment and retention issue as well to try and get the additional staff to support that. But at the moment we haven't extended. It's still in the plan to do so when we can.
Okay, thanks. My concern was just whether or not that was appropriate environment, if it was 24 hours for people due to go home, how they'd feel about it, that was all.
Yeah, certainly. But at the moment, we're just utilising it as fully as we can.
Thank you.
Any other items anybody wants to raise? If not, shall we move on to the board committee chair's feedback? There are written reports from each of the committees, but if we just run down them, see if there are any added points on quality and safety, Amanda?
Nothing much more to add, Chairman. The only addition was the slightly revised terms of reference to reflect quality improvement and our continuous journey of going to outstanding, really. That was all I wanted to raise. The other note is quite self-explanatory. We do have a meeting on Thursday as well, so
yeah. Thank you. Nikki, did you have something you wanted to pick up on those notes?
Is now the time to ask questions about those terms of reference?
Mm-hmm.
Yeah.
So there were a couple of things that my understanding was had moved from F&I to quality and safety, and they used to be in the terms of reference for the finance and the audit committee, and they aren't in the terms of reference for the quality and safety committee. So they were just the clinical audit and also research. So I just wanted to make sure that they weren't getting lost in between committees.
Thank you, Nikki. And in fact, we had a discussion on clinical audit and in fact had received, as you will see from the notes, the SNAP Sentinel audit. So I think perhaps we need to make that explicit in the revised quality, and I'll take those back to the next committee. Thank you for pointing that out. Pete,
Thanks,
could you
Amanda.
pick that up for us, please? Would that be helpful? Thank you.
Great, thanks, Amanda. Miranda, Pod, anything to add to the comprehensive note?
Yes, thanks, Chair. It is indeed a comprehensive note. The only other thing is I think that there are some issues relating to current operational pressures and staffing, which no doubt Steve will talk about when we get onto the IPR.
Yeah, okay, thanks, Miranda. Yeah, I think that's it's a key issue under concern for many of us. So I'm sure both perhaps Tara and Steve might be thinking of reference to that when we go through. Jackie.
Thank you. Just a question on the clinical apprenticeships. How many have we got in place?
Is that one for you, Steve?
Yeah, Steve might be able to help with that.
Yeah, I'm going to have to come back to you on the actual number for that, Jackie, if that's okay.
Okay, so that looks like an interesting one for us to kind of major on, wouldn't it? So I know it's early days, but just that would be helpful, Steve. Thank you.
Thank you. Audit, Paresh?
Nothing to add to the paper. I think happy to take any questions. The only thing I would add is that the finance team are now entering a period of heavy workload, especially preparing for the year-end audit and working with our external auditors to kind of plan the audit period for the last quarter. So just kind of as a note that the finance team will be under a bit of pressure.
Thanks, Paresh. Any questions on audit? If not, strategy committee, Jackie?
Thanks, Steve. Nothing to add other than the points that they're there. The next meeting is the 23rd. Open invitation to all NEDs as necessary, and you're all very welcome to attend. But as we've said there, everything's on programme. The two services, Cardiology and Ophthalmology, have now been to HOSC, and that's reported later in the papers. So happy for any questions.
Thanks, Jackie. And F&I, Nikki?
Thank you, Chair. My apologies that there wasn't a written paper. Some personal circumstances got in the way this week, or last week rather. So if I quickly whip through the headlines, if that's okay.
Yeah.
So the meeting was held on the 25th of November. So obviously quite considerable time was spent on H2 planning. And I suspect we'll come onto this in the IPR, the financial section of that. So I'll be brief, but essentially we discussed at length the fact that delivery of H2 is under considerable pressure. 3 key elements feeding into that. 9 million of H1 emergency recovery fund was not expected to be replicated in H2. There's a reduction in block funding, and the pressure due to the operation of the escalation wards are all contributing to risk in delivery of H2. Nonetheless, the Trust has agreed a break-even plan with the ICS, and current activity is overall in line with or above H1. And obviously the Trust remains focused on recovering activity. Month 7 financial performance. So month 7 was closed prior to finalising discussions with the ICS. So the year-to-date position was a £1.2 million loss, but that is expected to be recovered over the subsequent 5 months due to that break-even position being agreed. The elective recovery update, again, that will be covered later in this meeting, but just in summary of what we spoke about in F&I, the basis of calculation has changed to be based on clock stops, and due to that change in calculation, we don't expect to receive additional funding in relation to that in H2, which is part of the pressure mentioned previously. In terms of capital, it was noted that the Trust capital allocation for 2021 has increased significantly in year from £24 million to over £40 million, which is resulting in pressure on the Trust teams to deliver spend. A significant proportion of the programmes are expected to land in the final quarter of the year, which is normal. A number of tenders are expected to be received around the date of this board meeting, and there is now a subgroup of the F&I committee that is set up specifically to look at capital and facilitate delivery as far as possible in Q4, and there is slippage built into the programme. At the moment, it's currently anticipated that the full allocation will be delivered in year. In terms of the efficiency programme, the key headline remains that there is a gap between identified CIP and target, and that gap is currently £3.1 million. We should also be conscious that 68% of identified savings are non-recurrent, which will result in a significant challenge for 22-23 delivery. And then finally, we talked about the public sector decarbonisation opportunity, which I think will be coming to a board meeting in due course. And just to flag that the F&I committee was supportive of the estates team continuing to look at that project. So
great, thanks, Nikki. And the next meeting, I think, is later this week, isn't it?
Yes, Thursday, 2 days' time.
Yeah, great. Jackie.
I just wanted to commend the estates team on the amount of capital we've actually been able to spend this year and the schemes that we've done, which are, we talk about the pressure that we've been under, but the achievement is unprecedented really, because normally we can't find a penny. So that's very good, but also the scrutiny at F&I think gives a high level of assurance now on terms of process. So thank you for that.
Thanks, Jackie, and a point well made, I think. Good. Thanks for that. Any other questions to Nikki? Otherwise, let's move on to item 6 and to the Chief Exec's report, and over to you, Jo.
Thank you. Morning, everyone. So as requested, I've put a written report in, but the pace of change is quite significant. So whilst all of that's still valid, there's a few things that I probably want to draw to everyone's attention. But just to pick out a few things from the report at the moment. So I do want to start with a big thank you to all of our staff. It's an incredibly challenging time, and I think the reality of that is it's going to be challenging for the foreseeable future and beyond that. So I'll take every opportunity because people are working above and beyond. And I'm sure that the board extend that thanks as well. We are trying to balance urgent care, planned care, whilst trying to do some more strategic things, and obviously still ensure that we've got good governance in place. And I'll come back to some priorities that we've been asked to focus on over the next few weeks. So the report's sort of broadly focusing on trying to get that balance right and draw out a few things. So there are 4 national pilots that we've been either asked to come forward on, or we feel that we could, we've got expertise to be able to draw from that. Some of that's around data quality, and Tara may well pick up one of the particular programmes, which is really quite exciting, and we would only be the second in the country to go forward, but I won't spoil her thunder because it's quite an exciting. We've also managed to secure some significant amounts of money around EPR. And you'll see within the report there are a few data quality things that we want to explore and make sure that, and I think that's a bit picked up in audit, is that we want to make sure that we can continue to improve our systems and have some more robust programmes in place so that there's a bit more of a self-serve approach to data. I'll come back to some of the key areas of focus and risk in a minute because I think they'll be fairly obvious, but I'll draw them out. We continue to work well in the system. We've still got a good reputation across Sussex, and we continue to work at place level, so East Sussex, as well as Sussex level as well, as the ICS will shift into an integrated care board from the 1st of April. Tara's already mentioned Winter Sparkle, so again, I won't spoil her sparkle because she can pick some of that in the ops element. But what we've really tried to do is, whilst it's challenging, and you'll probably hear that word a number of times, we've tried to have a positive focus on that. So if it's going to be difficult, there's a mindset and a culture thing. So what we're trying to do is draw out the positives and the team approach and focus on well-being whilst trying to draw out some of the key operational priorities. A number of you, well, we've talked about that before in different settings, but that has been a focus over the last few weeks. But I know Tara will want to pick up a little bit more on that. Cardiology and Ophthalmology, again, I won't steal Richard's thunder, but we have formally started consultation on our cardiology and ophthalmology proposed changes, and that was from the 6th of this month, but so Richard will pick that up in a later paper. The bit I just wanted to draw out and put a little bit more. So because things change really almost on a certainly weekly basis, if not daily in some cases at the moment. So I don't think we can go through the board meeting without mentioning Omicron and what we believe is coming. So I think most of this is in the public domain already, but just to draw this out. So you'll note that the NHS has moved to level 4 incident, and the trust, our trust and wider NHS has been asked to prepare for what we believe is going to be an even more challenging time. And we know that that there are more cases coming through every day, either of Omicron or COVID itself. And we certainly have seen an increase. I know some colleagues will pick this up. So priorities over the next days, if I'm honest, and apologies in advance if Tara or Steve need to take a quick call and they'll explain a little bit why, because there's a few things going on that we need to get done today. So priorities will be urgent care and making sure that we can continue to care for the patients with COVID and make sure we've got capacity to do so, but recognising, of course, there are a number of other urgent care patients that are coming through. Not all patients have got COVID, but we need to be able to create some additional capacity. Vaccinations, we are absolutely part of that vaccination campaign. And I'm going to ask Steve to come in just at the end of my section just to talk a little bit about what we're doing on the vaccination. We were asked to step up a hub at Conquest, which is a patient-facing hub, which we haven't done before. And of course, with the news that we're trying to get everybody vaccinated over the next 3 weeks with their boosters, that plan has more than doubled in scope in the last, I think it's now 24 hours. So Steve's leading that, so I'll ask him to come in a minute. We do need to continue elective care, and we want to make sure we're focusing on our priority 2 patients, which are the patients that need to be treated within 5 weeks of being listed, our P1s, which is at 72 hours, and our cancer patients, which would sit within those contexts anyway. And we actually don't have any very long waiters. So I think we've got 1 patient over 78 weeks, which is for a specific reason. but we don't have, like many other trusts, patients over 78 weeks and 104. So they are the priorities, but it is likely as we, over the next, I think probably 6 hours, firm up our plans for the coming days and weeks, and certainly to get us past Christmas, that there may be some routine work that we do need to delay by a short while. And you might have questions of what that means. We really are working through that right literally as we speak now. And then maximising discharge. We've worked incredibly hard to discharge patients, but I think it is fair to say that we've probably got about we've got about 3 to 4 wards of patients that don't need to be in the trust and would be in a different setting. We're working really hard with our partners, but there just is a capacity gap. So we're going to have to look potentially whether there's some more innovative ways of doing that. I said if we knew what the answer was, we would have done it. But we're just going to have to get our thinking caps back on again and probably work with families to see how they can support over the next few weeks, because we do need to create some capacity quite urgently. In light of that, we are resetting our incident control. We had stepped that down because it was more business as usual, but we are resetting that to start tomorrow. We will have a gold in place. Again, this is sort of being worked on literally as we speak. And we will have some key work streams focusing on the front door, discharge, patient, staff welfare, etc. But I can brief a little bit more offline without going into too much detail, literally as it's being worked up at the moment. What I would say is that we've done this before and we know what to do. What we're trying to do as an organisation and a wider NHS is, rather than doing it as the COVID numbers start to increase, is we're making sure we've got really robust plans in place now and putting that in, because we know it's coming and it's better to, I think, get those plans in place and minimise disruption by doing last minute adjustments. But we've done it before and we can do it again. And our priority, and I will say this, our priority is to make sure that our patients are safe and our staff are safe. And that has to be our overarching priority at the moment. I'm just going to pause there. Can I just bring Steve in to talk about the vaccination programme and our role within that? And then I'm happy to take any questions.
Thanks, Jo. Thank you. And good morning, everyone. A week ago, we were asked if we would undertake or put in place a public vaccination centre in Conquest to deal with a lack of capacity in the area. This was going to be an out of hours operation, so effectively we run evenings and weekends. And whilst it felt like a big scale at the moment, at the time has probably become quite a small scale compared with the change in ask yesterday. Yesterday we were asked if we could set up full large-scale hubs, public hubs on both sites to support the effort to maximise the number of boosters. In order to do this, our aim is firstly to do it through discrete locations. In other words, do it in parts of each of the hospitals where we can, in essence, separate our vaccination patients from our normal patients. I don't know quite how else to describe it. Our vaccination customers, there we go, from our patients, so that there's no mixing between the two and we can keep them separate. And we've managed to identify locations to do that. Secondly, we're very aware, and we've talked about pressures. The word will come up a lot today. Across the organisation, we're very aware that we don't want the hubs to create additional pressures, so we're planning to operate them as completely discrete operations in their own right, so they do not interfere with and they don't get in the way of our other operations. And you can imagine that's quite a challenge in its own right, because effectively we're setting up new and different operations. Our aim through our aim through both centres need to be nationally approved. The assurance process is a complex and difficult process. We've heard this morning that Conquest has been approved. We've had a little bit more time on that, and we've done that, I think, in record time. Eastbourne, we are now working to get that approved. Our aim will be to deliver, through the two sites, will be to deliver around 16,000 vaccinations per week. So really quite high levels of vaccination. Like I say, that's our target that we're setting ourselves. It's a massive target, but it's what we want to achieve and what we think realistically we can achieve. Our expectation, if all goes to plan and with a fair wind, is that we will have both centres open next week. For Eastbourne, that will assume that we can get the assurance from NHS EI within the timelines we need. But what I do want to assure the board of is a couple of things. Firstly, that we are absolutely contributing to the national effort and we're throwing ourselves fully into that. But secondly, that we are doing it in a way which actually maintains the safety and quality of care of our other patient cohorts within the hospital, either as inpatients or through outpatients. I would like to thank the project team that have been working on this so far. I'll thank them properly when we've opened, because I'll feel better then. But the amount of effort that's gone into opening these hubs so quickly has been quite phenomenal, and it's quite humbling to see, you know, a group of people coming together to do things so quickly. So I think that's probably all I need to say on it for now, unless there's anything you want to add, Joe, if there's any questions.
I just one point really. So the eagle-eyed of you, you'll notice Steve is the Chief People Officer and this is a public vaccination. I think what this shows, is a big thank you to Steve, because this is a huge amount of work. But I think this is about drawing on the expertise of our executive team and rather than sort of looking at everyone within their specific roles, is looking at that expertise to be able to make sure that we're putting together as a single team. So I think here's a really good example, but I do want to do a big thank you to Steve as well. I'm happy to take questions, but I'm just, if it's the operational elements or for colleagues, I may direct it because they may want to pick it up in their IPR sections rather than covering everything now.
Great, thanks, Joe. Thanks, Steve. I'm going to exercise chairman's prerogative at the moment before I open it to other colleagues. I want to come to Steve first, but I have a question that's sort of between you, Joe, and Damien. Given what you've just been saying, Joe, about the instructions in the change of activity mix and so on, and the discussions that we've been having quite intensively, all of us at both F&I and at the board, about finances, and our view is always, as we know, that you know, safety for patients and staff comes first, alongside our ability to have sustainable finance. So is it possible at this early point to be clear about what are the consequences for our year-end finances in the light of all of this change? And let me give you a couple of minutes to think about the answer to that, both of you, and ask a more straightforward question of Steve, which is, I mean, apart from that, sounds like an amazing effort, Steve, from you and from everybody else. What kind of staffing do you think you need, and where is it going to come from?
Sure. Thanks for the question, Steve. We are thankfully we're able to operate as a nationally recognised public hub. We're able to operate under a different protocol to the protocol we operated under before, so we can operate under the national protocol. This means that we are able to use a broad range of registered staff outside of RNs, outside of nurses, in order to both consent for vaccines. And in fact, we're able to use the public vaccinators, the publicly trained vaccinators to deliver vaccines that we weren't last time around. So we're drawing on some different groups this time. We don't need to draw on our registered nurse population. Where we are looking at our services, and we are stepping down any services, if those services have any AHPs, for example, within them, we can draw on that group. There is a broader group of AHPs on the bank that we haven't been able to draw on for other services that we can draw on, and we can draw on the we can draw on the publicly trained vaccinators. So I think, thankfully, there's a much broader group, and in some senses, I feel more comfortable. This is probably a silly thing to say at this point, but I feel more comfortable about being able to staff these public hubs than I did about staffing smaller hubs under the PGD, the different protocol that we had to staff under before, which was far more restrictive. So there's quite a big population that we can draw on out there. That said, yeah, I wouldn't like to sort of understate how the challenge of getting the number of people in that we need.
Yeah. Okay. Thanks, Steve. So, Joe, can I come back to you with my more complicated question about the relationship with money? And I see Damien's got his hand up as well, so he can.
So let me do a very high level, and then Damien can come in. And obviously this isn't pre-rehearsed, so we'll see what he's got to say. I think some of this depends. If we have to step down activity, and I think there is an expectation that there will be limited to some extent, that does not mean a carte blanche stopping of elective activity. That's definitely not our intention. The risk is the elective recovery fund, and we have received a number of bids. We won't be doing, if we make any changes to our operational plans, that is going through an ICS conversation. In fact, actually, that's likely to be this evening. Providing we can continue to receive the ERF and the bids that we've put in, then actually we may not need to spend some of that on additional waiting list initiatives, etc. Because actually, we actually can't do any more elective work because we need to protect critical care as well. So there may be a win-win on this, and most of what we're talking about is not doing more. It's trying to reprioritise things onto fewer things, if we like. But it'd be interesting to see what Damien says, and he may well have had some further conversations in the last 24 hours at system level.
Thanks, Joe. Damien?
So firstly, on COVID costs, there's quite a well set up system for directly recharging costs that are incurred for COVID. So the cost of setting up the hubs is relatively straightforward. If we choose to, or if we have to incur some estates costs, we will have to submit a case. But at the moment, I don't think that's needed. In terms of how this impacts on half two, I probably need to go through my section of the IPR, because these things are becoming quite complicated. What I would say is we already had a challenge because the change of rules meant it was very difficult to secure any additional income for going above what was referred to as the 89% clock stops. So I think we had a plan that came very close. Well, what I think may well happen over the next 3 months is we will need to understand the scale of impact of COVID and the scale of impact of the vaccination plan in order to just keep going. But can I possibly come back to you after going through the IPR?
Yeah, yes, absolutely. I mean, I think the bigger point to be made, I think, is that if there are some trade-offs in our obligations and the commitments that we made at the beginning of the year, that's an explicit conversation we need to have as a board, isn't it? And all of us need to be clear about that and sign up to that. I think I think making sure we're on top of the money while everything else is so difficult is quite a challenge, but something that we absolutely have to do. And I think the history of the finances in this trust mean that we need to pay attention to that, possibly even more than might otherwise be the case, because we don't want to lose the very hard-fought gains that that staff have achieved in recent years. But that's a more general point. Let me bring Jackie in. I'm sorry to have hogged that a bit, Jackie.
Well, Chairman's prerogative, isn't it?
Indeed.
Just a couple of points. In terms of planning for these hubs, have we got an idea of the timeline? Are we planning 3 months, 2 months? Then my other question is there any thought nationally about using Nightingale for people who don't need acute care anymore, or COVID people? And then my third point was on the winter sparkle. Excuse me if it's my reading of it, but there's a sentence that says the aim is to reduce the need to reduce bed occupancy. I don't know if that's what we actually meant. So those are my 3 questions.
Do you want me to take the vaccination ones?
Yes,
Yeah,
please.
do you want to do that one? Yeah.
Okay. So in terms of timing for vaccinations, originally we were asked if we could set up till the end of January. Obviously, the target has been brought forward to December, but my expectation will probably be that we'll be looking through to the end of January.
Okay.
Sorry, your second point. I wrote the first one down. The second one has completely jumped out of my mind now. Sorry.
So don't worry, it was just whether or not, because if we've got 3 to 4 wards of people that need care but not necessarily in
Nightingale.
Nightingales, is there
Yeah.
is there a system response or something else? Because these people are not, we're not serving these people well, leaving them in an acute bed.
I know there's a staffing response. I don't know if you want me to cover that first, Joe, and then we can come on to the system response. But there's some specific concerns about our ability to be able to staff, not just us across the country. Nightingales.
Staffing, and then I'll
Yeah. There's some specific issues around the ability to be able to staff the Nightingales, because we can't magic up more staff. And I know that's been a concern with the Nightingales from the very beginning. And I'll stop there.
Understandable, but caught into a pint pot over spills at some point, doesn't it?
Yeah, so I think I haven't heard anything about the Nightingales being stood up in any shape or form. There is physical capacity in bedded capacity in the care sector. We'll come back to the workforce. So it's not the space that we need. This is a workforce issue. We have received a letter. We haven't actually received a letter, but I've seen a draft of a letter to look at to see whether we could step up community capacity to be able to support patients coming out of hospital. Again, all of these routes, if I'm honest, lead back to a workforce. And if we could, we're not going to increase our workforce by 30, 40, 50, 60 people over the next 3 weeks, or even the next 8 weeks. So the question is what we can do innovatively, and I think working with relatives to see how we can support relatives better to be able to allow patients to go home in a timely way, where that's appropriate to do so. We're trying to be creative about what capacity we've got out there, but the reality is this really does come down to a workforce factor.
And I think the point about social care and residential care is well made, and that's the staffing has got somewhat worse after the first and second wave of COVID, but also on vaccination obligations. So yes, there's physical capacity, but there's very few staff.
And just on the last point, which in the winter sparkle bit, and I'm just trying to probably a way of reading.
Yeah, sorry, it might be the way I've read it. It's just on the 4th line down.
Yeah, all I'm trying to say is that we need to reduce the bed occupancy, and the fact that there are additional wards open is because we have got because we need to either reduce our length of stay. So that's all I'm really trying to say, is that we were using winter sparkle as an opportunity to reduce our bed occupancy, or or to at least, well, yeah, that was the aim of it. So
can I sort of make one final plea, I suppose, is that we keep an eye on readmission rates, because I suppose my concern would be the pressure to move people out. We don't want people having to then bounce back in. So Tara's nodding, so I assume that we are keeping an eye on readmission. Thank you.
Great.
Did you want me to just come in quickly on that one as well, Chair? With regards to readmissions, we're working across the system with the Lightfoot report. And that is where, using the system that Lightfoot have been working on, they are identifying patients that have had a hospital stay of 14 days or over, and working with primary care as well. It's about making sure we monitor those patients so that they don't readmit. So there's quite a lot of system work going on. I won't say any more than that because otherwise it gets too in depth, but just to give you a flavour of how we're working across the system.
Thanks, Tara.
Thanks, Tara. Amanda.
Well, thank you, Chair. You actually asked my question. I was really interested in the staffing, but I also wanted to make a comment, and I wanted to comment on Joe. Joe, thank you for your written report. I think it articulates clearly some of the issues that you're dealing with, but I also recognise that this changes all the time. I just wanted to thank you personally and commend you personally, because the assurance that you gave me and the way that you described what you're doing with your executive team gave me such confidence and assurance. And I just wanted to say thank you to you. You seemed so in control of the agenda. And what you said was, we know how to do this. Yes, you do. And so thank you. And obviously there's huge amounts of detail that we need to address throughout the board meeting. But up front, the way you presented that just made me feel very, what is a very difficult set of circumstances, a level of confidence that I just wanted to express.
Thank you, and Amanda, and thank you to my team as well.
Thanks, Amanda. Karen.
Thanks, Chair. I just wanted to make a personal observation about the challenges of discharge, having spent a couple of weeks as a winter sparkle elf in our Bexhill rehab unit, which was, it's been really illuminating and a fabulous opportunity to actually work with the team. But I think what I've learnt, the thing that struck me most is it's not simply about getting patients out of beds. That's the objective. But the real challenge, and I think, Joe, you talked about one bit, was we need to work with families to help them. There are beds, as Jackie says, in care homes, and mostly the care homes seem to be quite good at taking the simpler patients. But the real logjam seems to be with the super complex patients, whether it's mental health or physical health. And I think there's almost a different question to be asked about how do you deal with those really complex patients. It really struck me how the other parts of the system, they could work faster, but they are flowing. So just, as I say, a personal observation, and thank you for the opportunity to be involved in Winter Sparkle. It was great.
You'll be able to put that on your CV now, Karen. I was a Winter Sparkle elf. A great accolade. Any reflections on that comment, but the substantive comment from Karen, Joe, or Tara?
Yes.
Yes. Yeah. Absolutely.
Yes, agreed. Yeah.
We are working hard, and it is part of the Sparkle campaign to work closely with everybody in the system to see what we can do to support, and we are even working where we can with homes to see what we can do to support them to take the patients back. So it might even be, and I'll use a really high level example of a patient where a home was happy to take a patient back, but they wanted a little bit more training on how to administer a drug. So rather than wait a long period of time for a team to come in and deliver that, we did it for them. And we worked closely with that team. So I think, you're right, Karen, it is an absolute minefield. And we are doing absolutely everything we can for our patients and going and working in very different ways to support those discharges. So yes, thank you for supporting all our elves. It's been really well received as well. It's great for the teams to see everyone involved in Winter Sparkle. So thank you.
That outreach is a great example, Tara. Thanks. Jo.
Probably going to, so we won't make this a whole discharge because we could probably spend 3 hours on discharge, but it is incredibly complex, Carolyn. I'm glad you've seen it really, because I just wanted to reiterate, we do work with a system. We have an integrated discharge hub, and it is a partnership with a common goal rather than separate organisations. There is the Enhanced Care and Care Homes programme, which Abby Turner is leading on, working to Tara on. So we are trying to do that, but yes, it's incredibly complex, as you say, but yeah, I won't say any more on it now.
Great. Thanks, Jo, and thanks for that overall report. Let's move on to agenda item 7, onto the integrated performance report, and start with quality and safety. Over to you, Vicky.
Thank you, Chair, and as always, very happy to take questions at the end. Just some things I would pull out to highlight, albeit we've probably covered some things in terms of challenges. So October feels a very long time ago now, actually. It was another extremely busy month with winter surge capacity open on Devonshire and Glynde and additional capacity on Murray. In addition, Polegate Ward at Eastbourne has been consistently open, frequently to 30 beds, and at times we've needed to have 2 other areas open. So as we've said, that really has continued to stretch the workforce, particularly the nursing workforce, and all of our teams are working hard together on a daily basis to mitigate that and to support. Unfortunately, that is likely to be a contributory factor, certainly regarding the increase in falls, and we've seen some hotspots on Devonshire Ward and at the Bexhill Irvine unit. Unfortunately, some outbreaks of COVID have also added some additional pressure and complexity with staff, as we know, needing to don additional PPE before they attend to patients. On a positive note, I think the reduction in pressure damage is reassuring, and I think that's a testament to our staff who are working incredibly hard, often in very challenging conditions. In terms of COVID overall, at the time of writing in the last week or two, East Sussex as an upper tier local authority was actually the highest in England, with a rate of 733, and at that time the England average was just 473. Hastings case rate at that point was 803 and Eastbourne at 751. In the last week, actually, those numbers have come down slightly. So the England average has now increased to 508, and East Sussex has come down slightly to 670. And the cases in the last 7 days in East Sussex have come down from just over 4,000 to just over 3,700. I would just urge caution that although there has been a slight reduction in the last week, it's doubtful that that will take Omicron into effect. And as we know, that there is frequently a lag between local population rates and any impact on our services in terms of attendances and the numbers of positive inpatients. When we were comparing in the last week or two, Hastings was the 9th highest in England, with Eastbourne in 16th place. So I think not to underestimate the local impact that COVID has had, certainly over the last few weeks. And for the first time, actually, we've seen a noticeable increase in cases of children under 5, and also the numbers in 10 to 14-year-olds was at twice the national average, and at that point was still climbing, so really quite significant for our local population. At times, that has impacted on our workforce, especially for some of our working parents. And we've seen a number of occasions where staff have been household contacts and have needed to isolate and or have tested positive. But I'm sure Steve will talk to that later in his report. Tara and Steve, I'm sure, will discuss in more detail the impact that that has been having operationally and on our workforce. Currently, the number of positive inpatients averages about 60, but that still continues to pose some significant challenges in terms of pathways and cohorting. We do still have some patients with COVID ventilated, and we also have considerable numbers of patients requiring non-invasive ventilation, and unfortunately we are also seeing some challenges in maternity. First and second dose vaccinations of our local population generally are good and are at or just above the England average, but booster doses are slightly lower, particularly in the 40 to 65-year-olds, and certainly in terms of the patients that we are seeing in the trust who are the sickest, they are in that age range. So we do continue to have positive patients in critical care, and that is a mixed picture in terms of vaccination status. And I would strongly encourage anyone who's eligible to come forward for a vaccination or their booster and indeed their flu jab. So we want to make sure that our local population don't forget about the importance of being vaccinated against flu. Despite all of those challenges, patient feedback overall is largely very positive, which is great to see. Unfortunately, complaint response times have been particularly low in October, but I'm pleased to say that that has improved, and actually in November the performance was at 37% overall, so 36% for our 35-day response and 44% for our 50 days. The divisions are extremely busy, so their continued support is much appreciated. In terms of fill rates, as discussed, these continue to be challenged. But I'd just like to thank Steve's teams in recruitment and our clinical teams and our operational teams who are all working incredibly hard to try and recruit to our new surge areas and also any vacancies in any of our other clinical settings. But I think it's fair to say that it is very challenged, and at times I'd probably describe the staffing as fragile. I'm happy to stop and take questions, Chair, before I hand over to David.
Thanks very much, Vicky. Happy to open it up to questions. It's a very comprehensive report.
Thank you.
Oh, Nikki.
I suppose I was just pondering this, Vicky, as I looked at and this isn't specifically your report, I think it was the IPR as a whole. And this is maybe more of a question for Steve almost. It feels like the driver to change some of these metrics and some of the ones that are more challenging is staffing. Does that feel right to you? And if so, I guess the challenge is there anything else we can be doing to change our vacancy rate or look at alternative solutions to ease the pressure on our qualified substantive staff?
So I'm sure Steve will want to comment in a moment. I think what I would say is that actually I would agree that if you look at the performance overall, some things are clearly being affected. I think it's very reassuring that largely quality at the moment isn't. And I think that is because staff are working incredibly hard to prioritise patient care. I suspect that will mean that there is an impact on flow and length of stay, on discharge, on documentation at times, because they are having to prioritise. But I think largely at the moment all of those quality indicators are holding. But obviously it is a concern about the amount of pressure that everyone is under. And I'm sure Steve will want to talk more about what we are doing, not just to support staff, but also looking at new ways of working, recruitment and other things, because there is a huge amount of work still going on. So I'll refer to Steve. I'm sure he'll want to say more.
Just really quickly, sorry, I meant to preface my question with that reflection that it is amazing that we aren't seeing those quality measures dip, to be honest. I think that's a real testament to the teams on the ground.
Yeah, I would agree.
Steve?
Yeah, thank you, Chair. I mean, I guess there's two limiting factors, aren't there, to what we're trying to deliver at the moment. And the first is our estates, you know, how much space we've got, number of beds we've got, and the layout. And the second is the number of people we've got to deliver the care. So I think, Nikki, what you're saying is correct. It is a limiting factor for us. Are we just accepting that? Absolutely not. There's a number of things that we're doing. Firstly, we need to be careful when we look at the vacancy rate, because part of the reason the vacancy rate has increased is actually because of some of the additional roles we're putting into ED, for example, to increase the numbers of people delivering care. So the vacancy rate in its own right is a bit of a mixed indicator, because the fact it's going up says, hey, we're investing where we need to be investing, and there's always a lead lag to fill that. But what else are we doing? There was a question about apprenticeships earlier, which I need to come back on from Jackie. We're investing a lot in new roles, in different ways of working, and looking and challenging our models of care and looking at how we can deliver them differently. I think one of the challenges for me is making sure that everybody is working to the maximum or to the best of their capability, and nobody's working a level below. So we're asking our registered colleagues to deliver registered activity. We're asking our healthcare assistants to deliver healthcare assistant level activity, so nobody's stepping down, so that we're absolutely getting the most out of everyone. We're looking at we're looking at different buddying models, different training models to put other people into wards and other areas in order to support those that are delivering the care. So I think what we're trying to do is we're trying to be innovative in every which way. We have a vibrant apprenticeship program, which is about growing people into new roles and different roles. We have a very vibrant now Kickstart program, which is about bringing new people into the organisation that will actually just ease some of the pressures and take things off elsewhere. We have a hugely successful international nursing program, which we're actually using not only to support our own organisation, but now to support some other organisations in the system as well that don't have the scale to do that. So we're working with the hospices, St Michael's, St Wilfrid's, to support them around international nursing, which again helps us in terms of flow. We're doing, I think, you know, we're trying to come at things really innovatively, and I think part of the reason for that is that actually, as this latest set of challenges around Omicron goes away, the challenges around staffing and around activities aren't going to go away. We still know there's going to be 90,000 nursing vacancies, or whatever the whatever the latest number is in the system. So we need to find ways to work around those. So actually, we're not just trying to put in place short-term solutions. We're really trying to look at our skill mix, our models of care, and put in longer-term solutions, which actually will give us a new and differently skilled workforce, which will mitigate against a whole bunch of the shortages which are going to be there for the longer term. I hope that goes some way to providing some assurance.
Thanks, Steve. Jo, did you want to add to that?
It was just, I suppose, and apologies if I misunderstood Nikki's point. I think what Nikki was asking was, or almost stating, was that the workforce was sort of almost a root cause of some of the challenges. Actually, I think the challenges, and without wanting to preempt Steve's workforce report, I think actually the challenges is the level of demand, and actually Steve just said, and the physical space to see all of the patients, which in itself becomes slightly inefficient, and a fatigued workforce. But actually, I think the root cause of this is that ability to match capacity and demand, and that demand has grown across a whole range of things. And we've spent a while talking about discharge, but actually, the fact we have got additional wards open primarily is because of our inability to flow patients out as soon as they don't need to be here. So actually, I think the root cause is that if we could get patients out quicker, we would reduce the need for those additional staff on those 4 extra wards, which in turn reduces the pressure on the rest of the team, which in turn, it improves our financial position and takes some of the stress and pressure off. So actually, I think that's the root cause. That said, there are some challenges in very specific areas. So for me, if we could get the patients out It's not all of that, and I don't want to blame everything. I know it would be quoted back to me, 80% of our patients go home on a P0, so they don't need social care or onward care. But with our population, our medical patients in the main do need something. So Tara will be aware. What we're trying to do is focus on the P0s as well as the long waiters, because that is within our gift. So hopefully, Nikki, that sort of, for me, that's actually the root cause rather than the workforce being the cause.
That's perfect, Jo. That was precisely where I was going. Like, where could we focus to have maximum impact?
Length of stay.
Jackie.
Thanks. I agree with all of that. That there is an issue of we're building up a need to do more. We're doing less electives. Our diagnostic target is not where it should be. Our front door performance has deteriorated after all the ground we've made over the last couple of years. So I accept what you're saying, Jo, about the flow through the hospital. But I'm assuming that some of the things we're doing, the plans for day case, the plans for diagnostic centres, will help manage that inflow volume, because I can see that as something that's going to be difficult for us once we get through COVID, because we're doing less electives, diagnostics are taking too long, etc., etc. So there is a bit about how we change the inflow bit, and the acute bit as well is needed. Because even if everybody moved out and we had four extra wards or no need for 4 extra wards, we'd still have issues with being able to do the amount of elective work and getting back to diagnostic targets and ED targets.
So I agree with the P0. What I would suggest is that Tara picks it up in her section and gives a bit of context of what's in place. And then perhaps if we need to come back and answer that, Jackie. But I completely agree. P0s and reducing length of stay and increasing day case does reduce the demand on the beds.
Okay, thanks, Jo.
Thanks, everyone. Thanks, Vicky. David, shall we take your section?
Thank you, Chair. Thank you, Chair. Just briefly to return to COVID, to add to Vicky's comments, I was on the Public Health for the South East Medical Director call yesterday morning, and they've been putting in some sort of planning suggestions for us, although this is all rather finger in the air stuff at the moment with Omicron. But the levels of Omicron are now rising exponentially in the southeast, but not currently in East Sussex. And whether that's because East Sussex was relatively high beforehand or not is unclear. But the likelihood is that it will hit us in the next week or so. And we've started to see, as Vicky said, some cases. There are a couple in the hospital, and I know some local teachers who have Omicron in their schools. It's mainly hitting the under 50s at the moment, which sort of is good news in terms of hospitalisation. But the over 50s are going up at a slower rate. The current doubling time is 2 to 3 days, but they're hopeful that with the new measures, if they're passed in Parliament today, it will go to 7 days doubling time, which will make it more manageable. The likely peak in the community, therefore, is going to be between 100 and 200,000 cases per day, and we're currently at around 50 in the UK. So that's between a 2- and 4-fold increase. What they don't know is how much that is going to translate into hospital admissions, because the early evidence is that Omicron is probably slightly less severe. But of course, if you have a whole range of severity, as is the case with all of the variants that we've had, and if you have very large community numbers, that will inevitably translate into significant increases in hospital. And they've asked us to plan for a peak roughly equivalent to the January peak this year, which was our worst wave. So we do have to be aware of that. And as Jo said, we've done it before, and we can do it again. Moving on to the mortality slide itself, we're still having some COVID deaths, not a great number, 8 in October, 15 in September. It has gone up slightly since then. In terms of the indicators, we were a little concerned, if you remember at the last board, the shimmy had been drifting up. Thankfully, it has turned and is coming back down, and the RAMI has continued to improve. And in fact, we're in the top 20% of RAMI across the country, which is really good. Why is there such a difference between the two? Well, it's largely because of coding and the way that the different indices look at coding. And I've been looking particularly closely at the shimmy because we have a much better shimmy at Eastbourne than at the Conquest. And actually it reflects the depth of coding between the two sites. And it's not that people are not clerking properly, junior doctors are not filling things in properly. It's actually a structural issue regarding the number of changes of consultant at the Conquest because of the way that they've been recording them, and I'm trying to work with them to get that the same as happens at Eastbourne. One good thing though is that the crude mortality rates are better this year than they were last year, even though the shimmy is still slightly higher. And so with that in mind, I think we can be fairly certain that there is no underlying fundamental mortality issue that we have to be concerned about. The bottom right graph on page 17 does show you the difference in coding between Eastbourne and Hastings, and although that has persisted throughout the last couple of years, both sites, the coding levels have come down a little bit during the last year, and we do need to address that. So just to be clear, this isn't our coders not coding properly. This is junior doctors clerking and not recording the issues properly, and then we need to work with them to get that right. And it's silly things like putting possible so-and-so as a diagnosis, which then can't be coded, whereas if you put probable, it can be coded. It's things such as if you put a differential diagnosis as your diagnosis, then none of them can be coded. If you use sort of quirky words like troponin positive ACS, which is effectively a heart attack, if you don't write myocardial infarct, it can't be coded as a myocardial infarct, although in your mind you've coded it as such. And it's issues like this, making sure that junior doctors write the right things in the notes. And of course, it doesn't just make a difference to mortality. If we were not in a block contract, it would also make a difference to our income. So these issues are important, but we're working on them. And I'll stop there and take any questions.
Great, thanks, David. But yeah, I mean, important to keep our eye on the fact that the overall position on mortality is really a very encouraging one, given the set of circumstances that we've been through, and we shouldn't underestimate the importance of that. Questions for David? All right. Great, thank you. Thanks, David. Staffing has been a strong theme already this morning, Steve. So over to you.
Thank you. And yeah, I'll take the report as read. And I think with every other performance discussion we've had today, the report only tells a part of the story, and things have moved on quite a bit. We've already talked about activity running really hot, and also talked about the fact that we can't sort of see this diminishing in the near future. I think I just really wanted to cover a few things just around the edges of the report. We are reviewing our staffing on a constant basis. I talked about vacancy rates a little earlier, and the fact that our vacancy rates have gone up. We've reviewed our ED staffing and our flows in order to assist with performance there. We're opening new roles where we need them. We're also getting better and better at planning early for our staffing needs. And are opening our shifts earlier and earlier, which I think has been a challenge for quite some time now. Now, the benefit of opening shifts earlier is we can get our temporary workforce colleagues on board, we can get them committed to working with us. I think the biggest issue, or one of the biggest issues we have around staffing now, actually relates to short-term non-availability of staff due to sickness and other reasons, because there's already a massive draw on the bank and an agency, and it just means there aren't people there to fill the roles at short notice that we've had before. And I'll come back to temporary workforce a little later to discuss that. We've also talked about the importance of getting people out of the hospital. Now, that has a number of impacts from a staffing perspective as well, having having a very, very busy hospital. Not only does it require more staff in its own right, but the fact that it stops the flow through the hospital inevitably leads to us having more outlying patients as we can't place them where we need to place them. And again, this has a real impact on the efficiency with which we can deliver care and the time it takes, again, delivering on our impacting on our care delivering colleagues. It also means we're constantly asking people to work in areas where they haven't necessarily been rostered. And we know that people don't like this. We know that it's challenging, but our ability to be able to react to the day-to-day pressures is really, really important. And it's one of the things that does keep our head above water at a time like this. So overall, staffing is really tight. We don't have the flexibility just to bring in additional staff as we used to. But we are, for every single shift, ensuring we've got safe staffing. We're moving people around to ensure we've got safe levels in each place. I was on call last night. One of the conversations we were having was around how many registered people we have in each individual ward, how many qualified and unqualified staff we have in each individual ward to make sure we're safe. And I think one of the things I do want to a group I do want to mention here are sort of unsung heroes that we talk about the people on the wards, we talk about the people in the clinics. I want to recognise the site teams for the work they're doing, which is absolutely incredible at the moment. And I want to recognise the on-call managers who are committing so much to ensuring that we've got a safe environment across the whole hospital alongside the ward teams and the other clinical teams. The role of the site team and the role of the on-call managers at the moment is incredibly difficult. It's incredibly challenging and it's incredibly draining. And yet every day I meet up with the site team or I talk to whoever's on call, I see smiles, I see laughter, and I see people working really, really hard and keeping their spirits up. If I come on to staffing numbers, the substantive staffing numbers have increased once again in the month, but the slight increase in turnover means that despite having 110 new starters, our net impact was just 12.3 whole-time equivalents in the month because of leavers as well. We ran a reset week for recruitment in November, which was really looking to bring forward recruitment, and we managed to bring forward 125 booked start dates in a week, which was incredible. We're also expecting 44 international nurses very shortly, and we've got further cohorts in the first 3 months of next year. To give you a flavour in terms of the levels of activity in recruitment, and Vicky mentioned this earlier, there's typically 900 open actions on our recruitment system, all of which we're delivering within SLAs. So the recruitment team are working their socks off at the moment to make sure that we're delivering there. We are continuing to be successful in the recruitment of consultants, and this is really encouraging. And I think we're still seeing the sort of the movement of consultants towards the coast that some of our other colleague organisations aren't seeing. We've had recent successes in radiology, gastro, maxillio, and orthopaedics as an example. And I think the orthopaedics one was a particularly positive and good field. Trust turnover at the moment is 0.4% up on the previous month at 10.5%. To keep that in context, that's 1% where it sat in March 21 and only 0.1% where it was a year ago. So we've got to be careful that we do keep it in context when we see it going up. That said, I do want to keep a very close eye on it. Around 10% of the turnover was due to the ending of fixed term contracts and other COVID roles, where obviously we work to retain people where we can, but some people, they want to work on a fixed term basis, on an interim basis, and around 10% of the turnover was related to that. In terms of the vacancy rate increase, it increased by 2.9% in the month, which is an increase of 281 FTEs, but that is largely due to increased funding of the emergency care pathway. The reliance on temporary workers remains high due to activity, and we filled about 22,000 shifts. So we had requests for about 22,000 shifts in month. It has reduced slightly this month for the first time in 7 months for all groups except AHPs and scientific staff. Fill rates remain a challenge because of the volumes of requests, but we've currently got 200 people going through the recruitment pipeline for our temporary workforce. Sickness levels remain a concern. We've had 6 months of increase in sickness. In November, we saw some signs of it reducing, but sadly, that has started increasing again, with COVID numbers rising from what was the late 20s, probably up to the late 30s, 38 today. Isolation numbers going from 60s to the low hundreds, 105 today, and our overall sickness levels back where they were over the summer. So they're not back anywhere near the peaks that we saw, but they're back where they were in the summer, with about 350 people off today. Anxiety, stress and depression, while still predominantly identified reasons for sickness, they've now reduced for 3 consecutive months, which bucks the trends of other trusts in the system. And what we're seeing is the typical reasons for sickness are the typical winter reasons that we'd expect to see now, alongside COVID-related reasons. And I am pleased that we're seeing the anxiety, stress and depression levels going down, because that's something that intuitively at the moment you might expect to see going up. Vaccinations. I've talked about public vaccination. If it doesn't involve a needle, it doesn't involve me, it feels, at the moment. So I'd like to sort of mention mandatory vaccinations now. This happened obviously after the report, but the announcement of mandatory vaccinations has created a new set of challenges for us, and a new set of risks. We've received the NHS guidance now, so we understand broadly who's in scope and who's out of scope. In simple terms, if you work in a ward, or you work in a clinic, or you're required to go into a ward, or you're required to go into a clinic to undertake your role, then you're going to be covered by the requirements. We estimate this puts about 6,230 of our staff in scope. We've confirmed the vaccination data for 86% of staff, which makes them fully compliant, and around 4% of staff who have had dose 1, but we don't have further information from them. That leaves about 10% of staff who we have no data. That does not mean they're not vaccinated, but it means we don't know, and it may be that they've had vaccinations elsewhere or through a different route. We've written to every single member of staff that we don't have data to confirm their vaccination status, and once we've got that, we'll put supportive measures in place for colleagues who are not going to be compliant with the new rules. The new rules come into place on the 1st of April, subject to the legislation being successfully passed. But in timelines, that means everyone needs to have had their first dose by early February. So we're working to a very short timeline on this. Another big challenge for us, and a risk to our staffing. Though, as I say, our worst case scenario at the moment is 10% of staff, and I am very, very confident that the number will not be anywhere near that. A somewhat fuller overview this month, Chair, but as you said at the beginning, we've spent a lot of time talking about staffing, and staffing is a very key issue for us at the moment.
Well, it always is, Steve, but thanks for that comprehensive and thorough briefing. Jackie.
Thank you. Thanks, Steve. That's quite assuring, some of that. I want to commend the Trust really on the progress we've made of our ability to recruit talent. When I first came here, we often get no applicants to posts, and we are getting some very high calibre now. So well done, everyone. And it's so important to protect our position on that. My other comment is on mandatory vaccinations. Having just been through this with the care homes that I'm connected with, we eventually lost 60 people out of a population of 1,300 staff, but a lot of the staff had a lot of difficulty producing the evidence because they'd gone to other centres or things like that. Hopefully, because of our staff hubs, we won't have that, but there was a real need to help people find the evidence. So I would hope that we're going to be aware that that's going to, logistically, with over 6,000 staff, that's going to be a real nightmare. So you're not out in the woods anywhere, Steve. You just come out of the hub and go into the proof room.
We've got a process in place where people can go online to upload their evidence. We're lucky that for anyone that has the NHS app, obviously they have the travel pass on the NHS app, and we are allowed to accept the travel pass and the travel proof as evidence, along with vaccination cards and various other things. So where we can, we're accepting those. What we're also doing is, where we're identifying staff that can't provide it, we are supporting them and working with them to help them provide the evidence, Jackie. So you're absolutely right, and it's something we're very aware of.
Great. Karen.
Thanks, Chair. Steve, great to see the progress on recruitment and the fact that it continues to be encouraging, because I think given the pressures nationally, we could have been worried that maybe it would dip as other people kind of learnt our skills at recruitment. So congratulations on that. One question, I noticed that turnover rate has kind of been just creeping up over the last 6-7 months. And so I wondered, how are we doing in terms of just general workforce churn compared with our ICS partners or others in the region? It's context setting, really. That would be helpful.
Yeah. We're no worse than any of our partners. If anything, we're performing slightly better than some of our partners. I think our health and well-being, our approaches to health and well-being are seen both within the system regionally and in some instances nationally to be absolutely leading edge, and our support for our staff is very, very good. So we're no worse, Karen, but no worse isn't good enough for me, and it's something that we continue to just really work on in terms of how we engage with people. Clearly, that's very difficult at a time like this. Our turnover is probably impacted more than many other organisations by the age profile of our workforce as well. And that's something we're very conscious of, which, taking the first part of your point, making sure we've got a really excellent approach to recruitment is key to us, because we will have a degree of guaranteed turnover because of the age profile of our workforce as well.
Thanks, Steve, and thanks for that report overall. Let's move on to access. Tara.
Yeah, thank you, Chair. So I'm going to take the report as read, and I think one thing that this meeting does show is how joined up the execs are. All my colleagues have referred to many areas that I probably was going to cover. So I'm going to bring us up a bit and celebrate some successes, because I think we've talked about the challenges that we have. We continue to see the high acuity, as we've said, through ED, but also the patients that are residing with us in the hospital. But on Friday, against all of the dark days that we've had as a trust, we were 12th in the country for our ED performance. So I think it shows, and it is absolutely testament to our teams, that we do bounce back quite well. And as nationally, ED performance is lower there where we'd all like it to be, but we are still up there and leading the way. So I think, again, that is real credit to our teams and to our system working to allow us to do that. To keep the ED performance flowing, this goes in part to Nikki's point earlier on, and I mentioned it at a previous meeting. We have implemented this month Livy, and there is a digital system that we've brought in that allows us to redirect patients that either come through 111 or appear at our front door to get urgent treatment centre appointments. We can triage those patients and give them a booked appointment through Livy with a GP, and the patient goes home and they have a booked appointment slot, and they can avoid the waiting rooms, but also still get the care that they want. We went live last week. This is still really in infancy, but in our second day, we diverted 17 patients. Might not sound a lot, but that can be the straw that breaks the camel's back some days. We diverted 17 patients through to Livy, and not a single patient returned back through to either the UTC or ED. So again, I think a success. We are the first to do that in the region. We have led the way there again. And a credit to Paul Cloves, who is our ED lead at the moment, because he has been absolutely the driving force behind this. So I think we will only see that go onward and upward. We are also working on the e-triage system, so patients can come in and they will be able to check themselves in through ED. They will be asked a number of questions, and then that triage will direct them to the right place. It might even be that it directs them to the local pharmacy, etc., etc. So we again are working hard on delivering that. So I think we must acknowledge the work that's going on, and also that our receptionists in ED and are managing this and trying to manage all of the other pressures that they're under. We continue to use and promote our ESHT, and we are also working really hard at the moment and starting to see a real uptake in the use of the ESHT. So our clinicians are seeing patients, and rather than keeping them in for a long period of time, they are coming back the next day or later on in the day to booked appointments through the ESHT. So that again is a way that we are strengthening our front door. As Steve has already alluded to, we have increased the establishment in our front door model, and we are recruiting to that, and we really are starting to see some uptake there. And we're not just going for an RN, we are looking at a paramedic practitioner. We are getting all sorts of really good people wanting to come and work at ESHT. So again, a real positive that we need to acknowledge. We've seen and mentioned how exit block has impacted on our performance. And so in response to that, we've referred to Winter Sparkle. So Winter Sparkle is an initiative that we've been running over the last 4 weeks. And the aim of this is really to streamline the patient pathway and provide the right care in the right place at the right time. And we've seen a number of work streams enabling us to do that. And some of that is around staff welfare offers. So I think Joe was a sparkly elf yesterday and went and served cake and coffee to staff. We're doing ward of the day and star of the day over the coming week as well. So we're doing all of these things to try and ensure that our staff are recognised and feel part of this whole process. We're already seeing results. So in the first weeks, we've seen a reduction in our length of stay from when a patient no longer meets the criteria to reside. So that is a set of criteria. Basically, that means that our clinicians have done as much as they need to for our patients, and it's just one more thing that they need to then be medically ready for discharge. So if I look at pathway 1, so those are patients that are returning home to their point of where they were admitted from, but with a little bit more support. So at the beginning of Winter Sparkle, the period from not meeting the criteria to reside to the period where they are medically ready for discharge was approximately 8.57 days. With what we've been doing through Winter Sparkle, that's reduced to 3.97. Now that is absolutely amazing, and that shows that we have changed what we're doing. We've brought our elves in. We are doing things that we need to do differently, and as I've already alluded to, some outreach things with other providers. And we've not done that as an acute system. We've done that with our community partners, with the local authority. Everyone is sparkling everywhere. I've probably put more sparkle anywhere than I've ever thought I would reach. So again, this is something that we're doing really, really well across our organisation. Now, electives, we have already talked about the fact that elective delivery has been impacted, and some of that is on the absences in workforce that we've already mentioned. And in some key areas, patients need the anaesthetist, they need to have an ODP, an operating department practitioner. And these are when these people go sick, or we have workforce issues, we can't resupply those people, and we have to take the list into, we take the list down, and then we relook and rebook the patients in the right order. We are doing, still doing amazingly well, considering the pressures that we're under, and everybody works every day to look at how we manage and can deliver elective activity. Some of you may be familiar with 642, so we look at our planning of our theatre list 6 weeks in advance, 4 weeks in advance, and 2 weeks in advance. We're actually doing 6421 now, and that is that we're looking 1 day ahead, and myself and the chief of the DAS division, Justin Harris, are working together in conjunction on that, and making sure that we are working with the clinicians to prioritise our patients. Where possible, we are moving patients into the day case environment, and even going one step further and looking at how we can move patients into a local anaesthetic, so that allows us to continue our throughput. And these are all things that we are doing and recognised as doing as well when we're looking at some of our high volume, low complexity activity. As an organisation, we were asked a question, well, why aren't you doing this particular procedure through day case? We've already gone one step further. We're delivering it in the outpatient arena. So we are ahead of the curve there as well. So we must recognise that we are still delivering against our H1 recovery trajectory, although we know over the coming weeks we're going to see some difference. We still have the lowest over 52 weights in the region. As Joe said, we aim for and have been delivering 0 over 78 weeks. We have one patient who has opted to wait for personal reasons, but we are managing that pathway completely. We talked about diagnostics. So we have seen a significant increase in our diagnostic delivery, and our additional insourcing that we've procured for echocardiograms is commencing, so we should see a step change there. We are also looking at the rollout of our community diagnostic centre, which again will further improve our diagnostic capacity and delivery, and also keeping it off of an acute site will make it a lot easier. I think, you know, when we look at our diagnostic activity, we have for the second month in October delivered the 28-day faster diagnostic standard, which again will go to support the delivery of our DMO1 and our cancer standards. We have recruited a winter director. He has joined the trust to support the operational oversight and has been described as a new battery to help us deliver the day-to-day performance. He's predominantly based on the Eastbourne site and he's doing wonders there. So, and again, you know, testament to him, he is driving some of these changes in thought process. We have yellow forms that we've started to use on the Eastbourne site, which allows the doctors that aren't going to be there over weekend to really give instructions for discharges over the weekend as well. So I'll try to just end again on another positive. Joe mentioned earlier on an exciting project with regards to the trust leading or being one of the first pilot sites, and that is Palantir. It's part of the Foundry project. And I'll describe it in my layman's terms. This is like a great big sticky plaster that we are going to put above all of our existing clinical systems. That then provides us with a single view of the activity that is waiting at clinician level. It will allow us to review harm reviews. It will allow us to do really good data quality cleanup. It allows for an audit trail when we are moving patients around, and the clinician is in control. The pilot site is Chelsea and Westminster, and the regional coups and some members of our team, we had a virtual show round of Palantir last week, and it really is exciting. What it does give us is the opportunity to all be looking at the same data at the same time. It is the elective module that we're looking at the moment. Various trusts around the country are being asked to look at other modules. Norfolk have been asked to look at the discharge module, but they're not making the progress that they know that ESHT could make. So it's quite likely that we will be asked to lead on the discharge and community element of that. There's a huge amount going on at the moment, and I have to thank the teams and also my exec colleagues, because there have been days when maybe we can't get everything done, but we pull together and actually we come up trumps. So it's been a difficult couple of weeks, and I'm sure it's going to be equally challenging over the coming weeks, but I know as a team we will do it. Thank you. Open to questions.
Thanks, Tara. Chief Elf, let me start with Nikki.
Thank you, Chair. That's a good segue, actually, because my question, Tara, was amazing transformation that the elves have brought about in terms of that length of stay figure, which I think is incredibly impressive. what assurance can you give, though, that that will continue to either be stable or continue to reduce once the elves have disappeared?
So I'm going to be honest, a lot of the elves are everyday people. Well, we've got a few elves helping, and we've cleared our diaries down to be supportive. This is down to the people on the ground, and a lot of this is around culture. And allowing people the time and space to actually think a little bit differently. And that is what we're doing. And that's what the elves have created, is a little bit of space and giving us time to look at our processes and make some changes. So, for example, Nerve Centre, we all know and love, and we are desperately trying to embed more. Simple things as in, we'll look on a daily basis, how many patients on Nerve Centre today don't have their criteria, their P status in Nerve Centre, in which case we need to go and address that, because how can we work through? So it's really about how we're changing our culture and supporting each other to ask the silly questions now and again that we don't normally ask. So in answer to your question, Nikki, I think it's everyone that's still there, but just giving them the headspace to be able to change the way of working, and maybe just that little shift will sustain us.
Thanks, Tara. Amanda.
Hi, Tara. Thank you again. A great comprehensive report. You mentioned the yellow forms at Eastbourne, which I'm quite interested in. And just wondered if so I understand, doctors can then write discharge plans for the weekend. Where are we at with nurse-led discharge, and how's that supporting?
So nurse-led discharge is on our list to do. I think it's probably not been as strong as we would like it to be, but the yellow form is the pathway and the segue to that. So it's really giving the permission for these are the next steps, and then they can go. So this is all part of the not meeting the criteria to reside and how we move these patients through. And again, it goes back to the point I've just made with Nikki. It's about giving people the headspace to be able to do it. Yeah. The other thing, sorry, Amanda, just so we lead back, is linking right the way back round to workforce, is about the amount of nurses that we have on the ground at the moment, and making sure that we've got the workforce to be able to deliver all of this and not putting too much pressure on people.
That was going to be my point. In terms of nurse-led discharge, has been something that has been fairly difficult to put in place for a variety of different reasons. And I was just going to ask what the kind of constraints are in terms of rollout, but I think you've articulated that. Thank you.
Thanks, Amanda. Jackie.
Thank you. It's so impressive to see the focus, and it's not top-down instruction, it's all working together, which is so impressive. I'm disappointed that the elves are just normal people, but that's upsetting. But just on the constitutional standards, there's a couple on the urgent care and diagnostic wait time where some people are doing really, really well. And my eyesight's too poor to see who they are. Do we know who's doing better, and is there anything we can copy from them?
I think really some of it is around backlog, Jackie. So we do reach out and work with our partners, and again, going through the whole process with Palantir as we go through this work stream, we will start to cleanse our data, because I'm going to be honest, I think there is an element of where we need to just make sure that our waiting lists are as clean as they can be, and that is something that myself and Mike McKernan are working on at the moment. And we have procured a company called Source. We're not sourcing a source, but it's a source that are going to come in, and they're going to do a review of 18,000 pathways for us, so that we will validate those. And I think what we will start to see is that actually some of the referral pathways in might have created duplicates, and we will be able to manage that. So this was one thing that we learnt from Chelsea and Westminster when they started doing this process, is actually the cleanliness of the waiting list is the most important at the moment.
Okay, thank you.
Thanks very much, Tara. Let's move on to finance, if we could, Damien.
Thank you, Steve. Can I start with just taking a backdated review of where we have come from? because there have been a couple of mentions of staffing numbers, and I think it's just important to put the context. So compared to our base year of 1920 to now, we have actually increased our staffing by 498 people. And the most recent increase in establishment that Steve mentioned was a step of 282 whole-time equivalents. And I just want to break down what that meant. It was the conclusion of our ward nursing review, our A&E nursing review, and the inclusion of some escalation wards, plus some additional changes that were dedicated towards H2, in particular the enhanced care and care homes. So as a package, what's important is it's not just changes to reflect H2. We have actually brought establishments in across medicine and ED to a level that those departments can now recognise, because up till now they were struggling to, they were consistently overspending against a target that actually we had never fully signed into. So that's the scale of change that we've had. The downside to it is there are obviously increases since a base year that is having an impact on us now. Secondly, I want to emphasize the move from months 1 to 6 to months 7 to 12. So in months 1 to 6, we performed relatively well compared to the national standard in terms of over-delivering against the elective recovery fund. So we secured in those 6 months 9 million of additional income. We're not expecting to deliver that in months 7 to 12 because the standard has become much harder to deliver because it's now based on clock stops. Instead, what we're trying to do is just be balanced about the level of H2 bids that we have secured and try to cover off that gap and make sure that the escalation wards that we've had to fund are covered within the H2 bid. So that's the balance that we're working with now. I mean, very briefly, and I have done this in F&I, we're looking at 3 gaps that we're trying to fill. There's the 9 million loss on elective income or not inability to replace the elective income. There's the 4.5 million against the escalation wards, and there's also an expectation for us to deliver a degree of efficiency of approximately 4 million. So those are the targets that we're facing. As we came into month 7, we have declared a loss of 1.15 million. And we are looking at declaring a loss in next month's accounts because they've just closed of another 400,000. We believe with a degree of rigour against the areas I've just covered, we're going to be able to get back to break even for the year, and that's the target we're putting in now. We are going to have to utilise 3 million of reserves that we had built up over the first 6 months, but that is the target that we're aiming for. Subject, of course, to the questions that Steve raised earlier, which is what's the additional ask from the COVID impact, and from clearly we're going to have to adjust our elective programme to try to make space for additional pressures from COVID. So can I just move on to the pressures that we're facing, sorry, the challenges in individual areas. I've already talked about the assuming that we're going to receive higher levels of income against the original year plan, and we're not assuming increases on elective recovery. We have seen an increase in pay costs, but that is mostly factored into our model for the next 4 months. And we're assuming that we're going to maintain spend on COVID, although there is now clearly a ceiling on that, and there's an expectation that there will be a reduction in total COVID spend at least post-April, although that does make an assumption about COVID dropping. Our challenge for delivering the year actually comes at the moment down to whether we can identify efficiencies. We've set out a table that says we are 3.1 million short of the full year plan on efficiencies. Through the end of month 7 and the beginning of month 8, we actually will be improving on that, and next month's report will talk about having a 2.7 million gap, and that does include us locally putting in a stretch target of 1.4 million. Actually, against the national reporting, we're only 1.3 million short. I know those are a lot of numbers. The basic message is we are still a bit short, but we are showing a degree of improvement against the efficiency target. Finally, can I just touch on capital? The capital position is basically we've obviously received some additional capital. We're now targeting just over a plan of just over 40 million. At the moment, the slippage we've seen so far has been built into an over-planning margin. So basically, we were expecting some spend to slip into next year in the first place. So at the moment, we are still on track on capital. We are saying that our final opportunity to review our capital position runs through to January, so we're taking a close look on when goods will be delivered and when estates programs will be completed. We are saying there are some risks in terms of completing the capital plan, but we will have a clear idea of whether we will be able to deliver that target by the middle of January, or during January, if I can phrase it that way. So apologise if I've moved slightly off script, because I just felt the sheer scale of what has been achieved just needed to be emphasised, given what's happened over the last couple of years, and given, yes, there are vacancies against the current establishment, but this is the first time that we've actually, we've had an agreement on an establishment, and you will see that feeding through in terms of Vicky's paper on establishment later.
Great, thanks very much, Damien. Let's open it up. Start with Miranda.
Thanks, Chair. I'd like to start by doing something I don't often do, which is commending the executive team for their efforts on a number of fronts, actually. We've heard quite a lot of very good news and tremendous efforts. Chair, at the beginning of the meeting, you mentioned some concerns which I share about the financial position. The incredible volatility of it is really now going to be heightened by some of the developments we've heard about this morning with opening up booster clinics and so on and so forth. What I wondered was, and what I don't pick up from anything I read, is are other trusts suffering the same difficulties with making it all add up and bringing everything down to the postage stamp at the end of the year? I am heartened, Damien, to hear you say that you think we will break even, or we believe we'll break even by the end of the year, but are other trusts in the same boat? And is there anything we can learn from them, or anything that we can get some support with from the centre as a result of that?
From the conversations I've had with other chairs, that our position is very, very similar. But Damien, you'll have a better feel than me.
So if I can just refer to South East, because I don't have the national picture, there are, of the ICS regions, and there are basically 5, six across South East. 2 of the regions are looking at fairly, on a deficit plan through to year end, and not being able to deliver their H2 target. The other 4 are all at the moment predicting a delivery. We have said there is some risk in terms of delivering year end, and in fact, Joe and I need to brief in a few days our plan to stay on target. There is still some risk, but to be honest, it's now down to under the 2.7 million figure that I've just quoted. So we think it is achievable, so long as COVID doesn't push us outside of those lines. There are discussions on income, and to be honest, we're having to make quite tough decisions on holding some of the H2 award to cover gaps in staffing and core spend in terms of non-elective, rather than additional programs that people are looking to kick off at this stage. But so long as we agree that position with the ICS, then at the moment it should be achievable. I should sound more confident, sorry.
I'll take cautious optimism. Joe.
It was just to draw out the establishment bit. I know we've got a paper on the establishment review. So it was a bit of a reminder to people, really, that we have obviously in previous years signed off increases to establishment, particularly around the nursing element. I think what had happened is it hadn't necessarily found its way into budgets. And obviously our COVID, our budgeting for last year and the COVID year was very different. So I think that the importance of having that baseline position has taken some time, but is vitally important, and it has been working through with the divisions as well. So that increase is not a sort of, they were prior increases, and I think, to quote Damien's words, establishments that the wards recognised but perhaps haven't quite aligned to some of the finances. So it's really important we've got that baseline position, and therefore Vicky's paper sort of draws from that really. So just wanted to emphasise that bit.
Great, thanks, Joe. Any other questions for Damien? Going. Gone. Thanks, Damien. Very a very helpful update. How you and colleagues are navigating your way through all of the ambiguity and complications and changes absolutely amazes me, I have to say. So that takes us to the end of item 7. I've not done a particularly good job again at keeping us to time, but I'm going to suggest we take a 15-minute break now, if that's okay with everybody, and if we could return at 25 to, slightly less than 15 minutes, but if everybody's good with that, see you in a short while. All right, welcome back, everybody. Let's move to agenda item 8 in the hope that David's back on the call.
Thank you, Chair. So this is the standard learning from deaths dashboard, which we report. In the last quarter, there's only been one possibly avoidable death, and numbers are right down in terms of deaths reviewed compared with the previous quarter, when we obviously had a lot of COVID deaths. What I should say, and I probably should have said last time, and I can't remember whether I did, is that the number of deaths last year, particularly in that last quarter, is going to need to be revised upwards. In the mortality review group, we look at all of the SI reports where there has been a death to see if there was avoidability. But some of the SI reports from the COVID outbreaks are only just being completed. And so we will look at those at the next mortality review group. And so it may be that the number of potentially avoidable deaths last year will be revised upwards. In fact, I'm almost certain it will be, but just to warn you of that. But apart from that, it's as read.
Great. Thank you, David. Any questions for David? No. Thanks very much for that, David. So let's move on to agenda item 9 on cardiology and ophthalmology. David, you're going to step out at this point. So just before I hand over Richard to you, I mean, just a few points of clarity. I think David has already obviously declared his interest in this. We're receiving these papers, I think, for the because the decision has already been made by the board to support this. Colleagues will recall that when that decision was made, it was Dr. Simon Merritt who represented the clinical leadership, not David. The paper that you've got in front of you simply reflects the decision that we already made, that we reaffirm our support for the models of care, and that those papers then had our support in consideration by HOSC on the 2nd, I think, of December. So if we have any questions on the process, I think Richard is able to say a bit about that, and then we can ask any questions. That's not a discussion about the model of care at this point. Richard, does that cover the general context, or have I missed anything?
No, Steve, thank you very much. You took the wind from my sails. Very, very helpful. I was simply going to state by way of introduction that this report, obviously, as you said, Steve, reflects the decisions that we made as a board on the 30th of November. Those two decisions that members will recall was around reaffirming our support for the two models proposed, and that we secondly were content that those would go to HOSC for consideration as to whether they were substantial variations, which HOSC subsequently, when it sat, said it was. What has changed since? Well, what has happened and what's underway is the consultation programme, which began on the 6th of this month, so it began immediately. And in terms of our actions, what's happening and what's taking most of our time at the moment is what we're currently doing is spending a lot of time just working through what that consultation programme looks like. So we are, so many of you will know that I'm not going to be around for the private board because we've started briefings with the MPs today. That's a joint programme, and so our comms team are working with the ICS colleagues comms team to make sure that we've got a sensible model of engagement, obviously one that's Omicron friendly as well, and we're in the process of pulling that consultation process together. So that's probably where I shall stop and take questions if colleagues have any.
Thanks, Richard. And I guess it would be correct to say, would it, that the consultation meetings, when they're finalised and etc., will be they will be clinician led?
They will indeed, yes. Yes.
Okay. Well, we've obviously looked at these cases a number of times, but I will see if colleagues have anything new that they want to raise, either with you, Richard, or with Joe. People are shaking their heads. Karen.
Just thinking about the Omicron situation, do we think there's any risk that the consultation would be extended in any way, or that the timeframes might change?
I don't think so. I think the legitimate question to ask is that, have we ensured that we have consulted as widely as we possibly can? Have we ensured that we are demonstrating we can be as accessible to people as we possibly can? And I think what the comms teams are looking at is to say, you know, when do we schedule these meetings? Do we offer the potential to do things face to face based on what government good practice is at the moment? I think it's about how we show through the consultation process. We know what the judicial review challenges have been in the past, so we're cognizant of those. So it's about making sure we've got a robust programme, even if that programme ultimately has to be virtual. It's about ensuring the accessibility for folks, and the teams at the moment are coming up with innovative ways of trying to ensure that we do all of that. So at the moment, I don't foresee that that's a huge risk to us.
Thanks, Karen. Anything else for Richard? Gone. Thanks very much, everybody. So that takes us to agenda item 10, the mortuary security assurance. Vicky and David, I think, are on this. David, back with us.
Thank you, Chair. So I'm sure Dr. Walker may want to chip in. First of all, apologies. For some reason, there's been a paste error with the paper in the pack. So my apologies for that. I will amend it and resubmit it. So the board may be aware of recent events involving a trust in Kent. And as a result, the NHS wrote to all trusts asking for mortuary access and post-mortem activities to be reviewed against current guidance. There was a letter sent in October and a subsequent letter sent in November. And in that letter, NHS England Improvement asked for a review of the Human Tissue Act, but also there was 4 main points that were required a review. This was really in relation to access points in the mortuary, CCTV footage, ensuring that there was a documented risk assessment of the facilities, and also ensuring that there's consistent application of DBS checks. In addition to that, all trusts have been asked to review mortuary and body store practices against the HTA Code of Practice. And indeed, the HTA are due to visit ESHT in February 2022, and that is a planned inspection, not in relation to any concerns. So there is a response to those 4 main points, and the board is asked to review that evidence, and if it is happy to confirm that appropriate responses have been taken to date. Also to note the HTA inspection, which obviously we will feed back to relevant committees, and also, if the board are happy, that any future updates regarding this matter and any action plans and guidance be reported to the Quality Committee and monitored there.
Great. David, I don't know if you're back on the call, wanted to add anything?
Yeah, no, I've nothing to add. I mean, apart from the typo where it's repeated, it's self-explanatory. We've reviewed ourselves against the HTA. There are some minor bits and pieces that we can do. We have an excellent we're lucky to have an excellent mortuary lead in the trust, Lydia Judge Cronis, and she is on top of all of this. And so I don't think we have any concerns that we should raise with you.
All right, thank you. Jackie first.
Thanks. Just a couple of points. I think it's really good that we're not having sole person attendance, particularly out of hours. So that is really, I think that was one of the key risk opportunities that existed. So I think controlling that is a really good idea. The other is just a question. Does our system allow us to know when the swipe card has been used and by who, so that we could periodically check?
Chris has raised a hand, Chair.
Do you want to pick that one up, Chris?
Thank you, Chair. Yes, Jackie, it does allow both those things that you've asked for. I was just going to add anyway, and so I put my hand up, that actually, whilst the report was being written, we've added 3 additional external door swipe card access to Eastbourne, which has happened since the report has been drafted. So that just gives us a bit more assurance for what you've basically just asked.
Thank you, Chris.
And that will be used to audit as well as just to control access, will it?
It will, Stephen. I think that's already covered within the report. It talks about how we're going to sort of manage and monitor access.
Yeah, yeah. Nikki.
It follows on from that, really. So it's reassuring to hear that we will be auditing access patterns. There was just one bullet point that just gave me pause, which was the maintenance team to be reminded that there is no access out of hours unless accompanied by a porter or on-call APT throughout the visit. The implication being that it is possible for them to access alone, and they have to remember to have somebody with them. I just wondered if that was the case, how we are monitoring that. So essentially, what does stop somebody accessing by themselves out of hours when there isn't anyone else around?
They'll be visible on the CCTV cameras, Nicola. So if they break the rules and do it on their own, we will A, know they've accessed on their own, B, have visible proof that they've accessed on their own, and a disciplinary process will ensue. So I don't think that they will do that.
Okay, so it's anticipated that we will have sufficient audit of CCTV that sort of activity would be picked up.
Absolutely, in light of what's happened not so far away.
Yeah. Is that a legacy hand, Miranda?
No, it's a new hand, Chair.
Apologies. So over to you.
That's all right. Thank you. I think a feature of the case that sort of kick-started the whole of this review is that the person in question also kept a large number of images of what he'd found in the mortuary on computer hard drives and on his phone, I believe. Are we doing anything to safeguard against that? Are people required to hand over their phones or cameras before they go into the mortuary?
It's an interesting question.
I don't have an answer for that at the moment, Miranda, and I don't know that David or Chris do, but we will endeavour to find out for you.
Thanks, Vicky. It's a good question.
Thank you.
Okay. Anything else from colleagues on item 10? And reporting through to Q&S, so there'll be a reporting route, and if necessary, reporting back to the full board if need be in due course, I guess.
Yes, indeed.
Thanks. Okay, thank you both very much. We have some annual reports for us to note. Workforce Disability Equality Standard. Steve?
I was just going to take the take the report as read, Chair.
Yeah. Anything anybody wants to raise on that? Nikki?
Just a quick one. The actions that are in the accompanying schedule, I just wondered how we identified those as being the most impactful.
The actions were pulled together with our ED&I team and also with the disability network. dis-ability network. So the actions have actually been identified and supported by the network group, which support this cohort of individuals across the trust, Nikki.
Happy with that, Nikki?
Yes. Was there anything else used as the basis for that at all, Steve, or was it mainly based on that network view?
Well, I mean, I think that I mean, outside of that, obviously, we've had consideration of our people strategy, of our values as a trust, and what we believe is right. But predominantly, the action plan was identified and agreed by our health and wellbeing experts alongside the network leads at a system level and at a trust level.
Okay.
So I'm not okay.
Jackie.
Thanks. Just on 2.3, can we amend datex to include that field on protected characteristics? I didn't feel it was the most user-friendly thing to adapt.
I'm sorry, I'm just going to the point. So when you say can we amend the field, I'm not sure I understand the question, Jackie.
Sorry, it's on the actions on 2.3.
Yeah, I've got it in front of me.
Yeah, sorry. It says November 21, protected characteristics field needed to be included on datex. So I'm just wondering, can we include it on datex?
Yes, we can include it on datex.
Okay,
yes.
thank you.
Yes, sorry.
That's all. That was all. Thanks.
Okay, there's nothing else on that. Safe working hours Guardian. Any questions for David? Anything you wanted to add, David? Anything?
Oh no, it's been discussed in great depth at pod. I don't think there's anything else to add.
On safeguarding for Vicky?
Thanks, Chair. We had a full discussion at the Quality Committee, just really thanks to all of our staff, all of our named doctors and safeguarding nurses. It's been a very challenging year and sadly a considerable increase in domestic abuse and domestic violence and child neglect. But our teams continue to work very hard and collegiately with colleagues in police and the local authority. So happy if there's any specific questions.
Yeah, and we heard some of that in our recent training, didn't we? Which was
the board seminar, yeah.
The board seminar, which is very insightful, I thought. Jackie.
Sorry, Vicky, it was just how our staff felt about having to revert onto just telephone surveillance, and whether or not they felt that then escalated their concerns, because there was thoughts that without face-to-face they couldn't always be sure, and I know that was a concern for some of our health visitors. And I'm not sure if the timeline works with this report, but I couldn't see it particularly drawn out in the report.
I think it's a good question, and it's one that has been discussed nationally recently with the sad case of the little chap who died, and I think rightly there is a concern from staff that when they are unable to see some patients, children or adults, face to face, then there is of course a risk that you're not able to see them in their environment. So I think that was why we made such significant changes after wave one. So making sure that we protected the health visiting service in particular, because of the need to ensure that they were able to see patients as much as possible in their own home. But I think it was a risk, Jackie, for every organisation, there's no doubt. And I think we're finding ways now to be able to have staff, community nurses, health visitors, community paediatric staff to enter patients' own homes, and sometimes to see some of the challenges that can be deliberately put in the way to discourage staff from going in. So, you know, not wearing a face covering, having lots of people in the house, not opening windows and stuff, because sadly there will be times when some people will want to discourage our staff from going in. But our staff are very clear about what to do in that situation, and they're able to step up their PPE and escalate concerns. So I think it would have been a feature early on in the pandemic when we knew very little about COVID and staff were not able to see patients in their own environment in the way that they would have done previously.
So we're okay now with the way we're working?
Sorry, could you repeat that?
Sorry, so we're okay now with the way we're working, that we're getting around
absolutely. Yeah, so I think very early on in the pandemic, clearly there was not an awful lot known about COVID. So I think the dramatic reduction in face-to-face contact with patients generally was a significant challenge. But I think that changed quite quickly over time, and certainly that's not the case now.
Okay, thank you.
Sure.
Thanks, Jackie. So you're on a little roll now, Vicky. You've got complaints next.
Thanks, Joe. I'll try and be quick. So again, this has had full discussion at the Quality Committee. It's been an unusual year in terms of complaints because of the distortion caused by the pandemic and various pauses. But I think overall, there are some highlights. We have digitised and streamlined the process to try and ensure that it is as efficient as possible. We have seen more of a normalisation in terms of the number of complaints that we would typically see, albeit that seems to have settled at a new lower baseline. I think I've already talked about our performance with regard to response times, which unfortunately was very challenged over the summer and into the autumn, but that is improving over the last couple of months. So I'm hoping that we can try to maintain that over winter, albeit I suspect that will be a challenge, particularly for the divisions. But nothing specific really to pick up from my point of view, but happy if there's any questions.
Jackie?
Sorry, I know I'm being a bit verbose. When we get a response from or outcomes from the PHSO, are those shared? Do we learn from them, and does the Care and Quality Committee see the detail of those?
So we do share. I mean, we have a relatively low number actually that go to the Ombudsman, and an even smaller number that come back with recommendations, because not all of the cases that go to the Ombudsman are upheld. So they certainly are shared. I think it's a fair point, and I'll speak to Amanda as chair of the Quality Committee to make sure that she's happy and the committee are happy that we have oversight across the whole trust. They can be quite specific sometimes to services, but we'll make sure that if there's anything that's more generic, then we take that to the Quality Committee.
Amanda.
Chair, just on that note, I mean, Vicky's articulated it beautifully, but the Quality Committee has been looking at our response to complaints, and I think it is particularly challenging given the time, and it's a priority. So we have been looking at processes, how we can improve that for feedback to our patients in particular. So, Jackie, a point well made, and I think this needs a total review, and we will keep our eye on it.
Thanks, Amanda. Shall we move to the nursing establishment, Vicky? People have referenced a couple of times already this morning.
They have. So the full report is included in the pack, and it's quite detailed. I would say that we had a considerable discussion at the Finance Committee. Just a couple of things I would pull out. So this establishment review relates to our bedded areas, so our wards, not all nursing. And we had quite a discussion, and a helpful discussion, I think, at the Finance Committee about when we talk about other nursing establishments, which would include specialist areas and specialist nurses, but not the wards. There were three options in the full paper, with option 3 being recommended, which was to fund a small number of posts in one of our elective areas, and that was supported and agreed at a cost of just over £500,000. And that was on the basis that we couldn't be certain that the last review and the last year weren't quite anomalous because of the effect of COVID on our footprint and on some of our clinical areas. So we want to be certain that that's not the case. The next establishment review for the wards is actually already underway, and we collected data in November, albeit that might be slightly distorted because of some of the changes that we had to make quite quickly during the month in terms of capacity. We're also doing some system benchmarking, and my thanks to chief nurses at our partner trust for that. So we will be bringing back the next establishment review and see what information comes out of that. But thanks to the Finance Committee for supporting the recommendations. I'm happy if there's any specific questions.
Thanks, Vicky. Anything anybody wants to raise with Vicky? Jackie.
Sorry, just on the comment on urgent care and cardiology, would those business cases then fall into the budget setting process, and what's the timeline for them?
So I don't know if Damien or Steve would want to comment. So this review is very specifically about ward-based services, and we have mentioned where there would be considerable change to a speciality or an establishment, which would be likely to require quite considerable investment, that would be a specific and separate business case. So I would say yes, and that would be part of the normal business planning and budget setting process. Steve is nodding, so I'm saying the right thing. But I don't know if Steve or Damien want to comment.
Damien, you've got your hand up. Do you want to?
We have to go through a formal process with reference to the ward nursing, and that's what we're doing at the moment, which is part of the national requirements. Admittedly, we're we're over a year late in terms of getting one through. The point about cardiology, yes, I totally agree with Vicky. That could be a process that comes into the annual budgeting process. But can I just make the point that we also need to link this to benchmarking, especially when you talk about areas like cardiology, because actually some areas of our service are significantly above a benchmarked comparator trust. So can we hopefully some of these staffing levels can actually come down as well as go up.
Yeah.
Okay.
Fair point, I think. Nikki.
To be fair, Damien has pretty much made my point, which was just whilst F&I was very supportive of the ward establishment nursing review, we did request that the trust take the time to benchmark other areas of nursing and actually more broadly, so that we were comfortable with overall establishment and staffing spend. So it was within that context.
Yeah, Vicky.
So, Chair, just to assure the board that I've already had conversations about that, Nikki, with Kirsty, and I'm sure there'll be conversations that we continue to have at the Finance Committee, and I'll be supporting any work on other nursing establishments, specialist nursing posts, outpatients and areas like that. Clearly we'll be working closely with the divisions because they'll need to be absolutely engaged in that process in terms of their services going forward. And I'm sure myself and Steve and others will have other conversations about the bigger people review and the other establishments that are not related to nursing or allied health professionals.
Thanks, Vicky. Any other points on the nursing establishment paper? Otherwise, thank you, Vicky, for that and the others. Let's move to item 12, disciplinary procedures. Steve?
Thank you. This is a somewhat odd item to
I'm glad you said that, yes.
To reach board. So it might help if I just give you a little bit more background. to the item. Some of you will remember back in 2015 there was an incident at Imperial where sadly through a disciplinary policy that probably didn't go, well, it didn't go as well as it should. Sadly, an employee took their life. There was an independent review of the situation at Imperial, and there was a report that was produced which made a number of recommendations that should be taken by Trust with regards to the disciplinary policies, and that these recommendations should be taken through a board committee in order to provide assurance that they were completed. We did that in July 2019, and you have all of the papers as a part of the pack for that. It's since transpired that there have been a number of trusts that actually didn't complete that process, and as a result of that, there was a further request. Firstly, that each organisation was to reconfirm to its board that it had completed the process, and secondly, that its disciplinary policy was actually posted on its trust website. Now, I have a view as to posting one policy on a trust website and how ideal or appropriate that is, but we have had a directive that we are to do that. So the purpose of this this item is quite simply to reconfirm that in July 2019 we completed the process as requested. We continue to review our disciplinary policy since that point, and it's also to confirm today that the disciplinary policy is now on our website in line with the directive. So that is the that's the purpose of this paper.
Thank you, Steve. That makes it very clear. Any questions for Steve? Okay, thanks very much for that, Steve. We've a couple of other quick items. We've got meeting dates for next year for people's diaries, use of the seal, and unless there are any questions on those two, I'm going to move then to questions from members of the public. As is often the case, we had a detailed set of questions from Mr. Campbell, one of our regular contributors. Joe, I'm not sure whether we were simply going to answer those detailed questions in writing in our usual way, or whether you wanted to pick out any of questions from Colin.
No, I saw the questions yesterday, so I think we'll reply in writing. The only thing to acknowledge is, given the context of what we spoke about at the first beginning of the meeting, our priority is just making sure that we've got our services in a good place prior to Christmas. So it may take a little bit longer to provide those responses, but we'll respond directly to those.
Okay, thanks for that, Joe. Liz, I know that you're our only member of the public on the call, and I know that we're meeting, is it later this week? I think it's later this week. Any questions that you have for the board, Liz?
There were just a couple or so. In item 7, Vicky mentioned problems in maternity, and I just wondered what those were. The other question was to do with cardiology and ophthalmology. With single sighting, could it be included the cost of a taxi fare for patients if single sighting does occur, which obviously is going to happen, because taxi fares have gone up hugely. And I heard of somebody that just went to their local GP practice and it was £14 within Eastbourne, which was a huge amount. And lastly, just to remember, when you go to public consultation and digital, not actually meeting in person, I just think that there is a danger that those that are most affected don't actually contribute, because they either don't want to, can't, and what's going to be done to address that. Are all patients that say are under cardiology, are they notified that they can take part and can write or do something other than digital? Anyway, those are my questions. Thank you.
Thanks, Liz. Let me take that second group of questions about consultation first, and then come back to Vicky's point about maternity under the RSM report. Richard, Joe, do you want to pick up that process question?
Yes, so thanks, Liz. So on the digital point, I think this is precisely what the comms teams are wrestling with at the moment, which is how do we get out to the voices that we don't hear often enough, and just relying on Teams meetings isn't going to cut it. So I think they're looking at a number of ways that we could do that. The cardiology patients, again, those affected patients, that they're part of the consultation in the way that we all are. So I don't think they're necessarily being picked out and specified in particular. But what we are trying to do from the inequalities perspective is to make sure we do get to the hard to reach patients as well. So that will be bound up as part of the consultation. Those are the things that the comms teams are working through.
Thank you.
Thanks, Richard. And the point about the cost of taxis.
I think we can certainly look at that. I think we need to look at the type of patients it impacts, but definitely we can throw that into the mix.
Well, and I think particularly with ophthalmology, although it doesn't affect Eastbourne, but Hastings, you know, even though it's only 6 miles, that still might be a considerable cost, and particularly with eyesight and possibly not being able to navigate onto a bus.
Anything you want to add on that process, Joe? Are you happy with that?
No, I think I know we're meeting Liz and there's a separate meeting. I think it's helpful to have all of this in writing, because then it can formally be considered and responded to as part of the consultation. But the formal consultation documents are obviously already out there, so it would just be good to have that in writing, Liz, so we can collate it and don't lose any of those points.
Thank you.
And Vicky, the question about problems in maternity.
So thanks, Liz. So apologies if I wasn't clear. So I think this is in relation to the discussion about COVID, and unfortunately, not unlike other trusts, we have had pregnant people test positive for COVID. Some of those have gone on to be critically ill, sadly, and also not all of our pregnant people are fully vaccinated. So unfortunately, we have seen instances where that has resulted in quite significant illness, but all of our teams continue to provide advice and guidance to pregnant people. So that was what I'd meant when I referred to maternity. Not that there are concerns about the service, but unfortunately the impact of COVID at times has been quite significant.
Can I just ask there, no, not being medical, and I don't want to be asked medical questions, but I have been asked several times, because there have been people that have been talking about the problems of getting COVID when you're pregnant. What is the advice now? Because it's been, are they supposed to have their vaccinations as normal, or what is the actual?
So they are, and David has immediately put his hand up, but the advice is absolutely. I think very early on in the pandemic that wasn't initially clear, so I think there was a lot of discussion about whether or not it was safe and the right thing to do in pregnancy. I think since then there's been a significant amount of evidence and information and reassurance, but I think it's understandably very difficult for pregnant people when they're making decisions about immunisations and medications, not just for themselves, but for their baby. So I'm sure David would want to comment, but absolutely it is safe, and our midwives are supporting people to make whatever decision they feel they are happy with. David?
Liz, this is something I feel really passionately about. A lot of pregnant women are putting themselves and their babies at risk at the moment through false information that was around at the start of the pandemic, and also false information that's still circulating on social media. that there is absolutely no evidence of issues with the vaccine for pregnant women. Hundreds of thousands of pregnant women worldwide have been vaccinated now, which of course they hadn't at the start of the pandemic, with no evidence of problems related to pregnancy. However, what we do know is that if you get COVID in the 3rd trimester of pregnancy, that puts you at increased risk, partly because, of course, you can't breathe that well because, you know, you can't lower your diaphragms as you breathe in because the baby's in the way, but also there's a risk of the baby becoming infected, and that can lead to complications as well. And in fact, there was a frightening statistic recently that 30% of women on ECMO, which is the highest form of cardiovascular support that's available in tertiary centres, 30% of the women were unvaccinated pregnant women, which is a bit of a scary statistic. And so I've been certainly putting out lots of comms for hospital staff who are unvaccinated because of pregnancy or planning for pregnancy. And there's a lot of information in the public domain now from the Royal College of Obstetrics and Gynecology about this. But so anybody who asks you, please reassure them that it's okay and tell them to get on with it ASAP.
Yeah, can something be put on the website? And also, I'm sure it might be on the website, sorry, but if it's not, can it be put on the website and made absolutely clear? Because I just said ask a midwife, because I wasn't, you know, they were asking me at different points in their pregnancy and I thought, I don't know. But if there's absolutely, it's definitive, you have, you know, get your vaccinations, then I think it would be quite good to put on the website. And also parent, you know, antenatal groups. Thank you.
Thanks, Liz. That was pretty unequivocal, wasn't it? Sometimes things are not straightforward. That was pretty clear and unambiguous. I thought. Thanks for those questions, Liz. So that brings us to the end. I seem to have recovered from my poor start in managing our time. Steve in the chat box has added in an answer to the question about apprentices. Do you want to just say what that is, Steve?
Sure, Jackie. The number of clinical apprenticeships we're currently running is 84.
Thank you. A good start.
It's a good number.
It is.
It's a good number. Okay. Thanks very much, everybody, for your participation. Our next public meeting is on Tuesday, the 8th of February. For those involved in the next stage of this meeting, we reconvene at 1 o'clock and see you then.